Good afternoon, everyone. Welcome to our new Women's Health webinar series, The More You Know. It's jointly hosted by UW Medicine and Right as Rain. We packaged up a 5-webinar series every 6 weeks to offer you helpful and timely information about health concerns you may have for yourself and your loved ones. Some of the topics our experts will address include screen time for kids, race and medicine, and midwifery. That's for the next 2020 through 2021 year. Webinars will be posted on the UW Medicine YouTube channel, and the next one will be in November. We'll be sure to email everyone who's registered today. We're kicking off with the more you know about gynecologic cancer because September is Gynecologic Cancer Awareness Month. Did you know that many patients are not aware that the gynecologic oncology specialty exists? They may seek treatment with an OBGYN or medical oncologist when faced with a gynecologic cancer-related issue. But studies show that women who are treated initially by a care team headed by a gynecologic oncologist experience better outcomes. Today, we're going to look at 3 of the most common gynecologic cancers and talk to 4 specialists. We'll look at 3 cases, which include questions about each type of cancer, and we'll learn a lot along the way. If you have questions, please submit them via the chat function below. We also wanted to acknowledge that we've received a set of questions from a couple current patients, which we hope to address towards the end, but this will be a 101 to the 3 most common cancers. Our moderator today will be Dr. Heidi J, who is Division Chief of Gynecologic Oncology in the Department of Obstetrics and Gynecology at the UW School of Medicine. She practices at the UW Medical Center Montlake campus and Seattle Cancer Care Alliance. She and her colleagues were the principal investigators in the clinical trials for PARP inhibitors, novel oral therapies that were then approved and shown to have improved survival rates for some cancer patients. Immunotherapy is a big area of interest in all of our gynecologic cancers, and we have some active clinical trials enrolling patients at SCCA to help answer the question of their therapeutic value. Welcome, Dr. Gray. Thank you for moderating the panel today, and thank you for introducing the other panelists.
Great. Well, welcome. Thank you, everyone, for joining us today. Really excited to talk to you and share with you some knowledge about our most common gynecologic cancers. It's a mouthful to say gynecologic oncology, but I've been saying it a long time. And so really thrilled to be joined today with some of my colleagues, Dr. Jen Burzawa, she can wave there on the screen, who practices both here and is at Valley Medical Center as well. Dr. Elise Simons, who practices here at, I keep saying here, I apologize, it's UW Montlake campus, but she's also practices at UW Northwest. And then Dr. Renata R, who might give a little wave as well too, my colleague who is here at UW Montlake. So again, really excited to talk today. We formatted this webinar around kind of a couple cases with our 3 main cancers, uterine cancer or endometrial cancer, ovarian cancer, and cervix cancer, and kind of questions that come up from patients about new diagnoses and screening, not focusing so much on treatments per se, but really kind of on diagnosis and screening of these cancers. So let's look at this next slide. So the first case is around uterine cancer or endometrial cancer. And one of the questions that can come up is women kind of wondering why they're still having periods at their age, or what's kind of normal when when should you still be having periods. And so the case would be a woman, J.A., 58 years old, who is chatting with her friends and wonders aloud, why her periods won't end, and she's really tired of having to buy tampons and pads at her age. And so this case is, and talking a little bit about this uterine cancer, endometrial cancer, is going to be Dr. Elise Simons. And so we'll kind of go through some of these questions, but please feel free to add things to the Q&A, and we'll try to answer them live. Okay, so
Hi,
hi, Elise.
thank you, Dr. Gray.
Dr.
Yeah,
Simons.
so this is just such a great question. Oops, I can't see the slide anymore. But the you know, it's a really important question to talk about, because one of the things that we need to emphasize is that there is a sort of a natural period of time in which people's menstrual periods should stop, actually. And actually in women in this country, the average age of menopause is somewhere around the age of 50 or 51. And so the fact that JA is well beyond that and posing this question is kind of our first clue that maybe there is something more that needs to be investigated with that. And of course, you know, it's a bell curve, right? So there's going to be outliers on either side. Some people are going to go through menopause earlier than that average age, and some people much later. And so it doesn't necessarily mean it's completely abnormal, but it is something that's worth seeking evaluation for in that case. In terms of when to seek medical advice or care for bleeding issues, you know, broadly speaking, the concept or the definition of abnormal uterine bleeding is anything that's abnormal in its frequency or its timing or its duration or its amount, right? This encompasses just a really large spectrum of potential symptoms. And so, you know, it's important that if this comes up, right, as JA is asking this question, that would be a very appropriate question to ask her medical provider about, you know, is it normal that she's still having periods? Is there anything else that needs to be investigated with regards to that? So if your bleeding is heavy, or it's coming more frequently, or more painfully than before, anything like that, it's worth evaluating.
Let me just interject there for a second. So just to kind of reemphasize. So in this particular case, a woman who is 58 and still having periods would definitely want to advise that woman to come in for some medical care, because that would be outside the range and would need some additional work, would be your advice. Right?
Correct. Yes, absolutely. Yes, yes. And in terms of what she could expect if she did come in to see somebody about that, you know, there are a few tests that may be ordered. If her bleeding is particularly heavy, her doctor may order some blood tests to see if she's anemic. The doctor may order an ultrasound to evaluate a pelvic ultrasound specifically to evaluate the uterus and the ovaries and see if there's any anatomic explanation for what's happening. But really, the most important test that she will undergo in the course of this workup would be a biopsy of the endometrial cavity. And that can be done either through a biopsy in the office, or sometimes, if that's not possible, sometimes it's a minor surgical procedure to get some tissue sampling from the inside of the uterus.
Yeah, that's what I was going to ask. Is that an office procedure you can have done, the endometrial biopsy?
Most of the time, it's an office procedure that can be done. Yeah, yeah.
Okay. So then talk a little bit about endometrial, or sometimes we kind of coalesce that to uterine cancer. You know, so, you know, how common is it? You know, how is it? And maybe just talk a little bit more about some of those logistics.
Yeah, so endometrial cancer or uterine cancer is the most common gynecologic cancer, actually, that we see by a pretty significant margin. I think the last estimate I saw is that it affects somewhere in the range of 1 out of every 35 to 40 women. And it's actually one of the only GYN cancers for which the incidence is actually increasing at this point. The good news is that most endometrial cancers are diagnosed early in their course and do have a very good prognosis. And so with appropriate intervention, this is an opportunity for us to intervene and treat women with this disease and still have a very good outcome.
What's the most common type of treatment, or do we offer women for endometrial cancer?
Yeah, in most cases, the appropriate first step would be a surgery, which would include a hysterectomy, and usually removal of the ovaries and fallopian tubes and some evaluation of the regional lymph nodes around the uterus to determine whether there's been any spread to those areas.
Okay. So a couple of questions came in that I wanted to answer live. I don't know, because I know Renata fielded one of them. Did that go to the whole group then? Did the answer go? Well, anyway, so one of the questions that came in was if one was already taking or was taking birth control at over age 40 to control some heavy bleeding, would that make a difference as to the age of menopause?
No, that should not change the age of menopause, but it may make the interpretation of the symptoms a little bit different. Yeah.
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 And again, just to kind of clarify, I mean, for, technically, menopause from a, medical perspective, as we say, if it's been a year since you stopped having periods, okay, then you're technically in menopause. But there's a lot of other parts of menopause, symptoms such as hot flashes, night sweats, things like that. And so I think Dr. Simons was saying that you may, stop having periods, but the birth control pills would probably hide some of the other symptoms like hot flashes and night sweats.
Yeah, and that's a great point, Dr. Gray. And one of the things that's come up that my patients have asked me is, well, I never stopped bleeding, so I never was sure that I went into menopause.
Yeah.
And that just gets at the importance of this case that you presented with JA. She never stopped bleeding, but she probably is menopausal. She's just bleeding for other reasons. And so it's important to understand that that sort of distribution or expected age of menopause and why that's so important to be evaluated.
Okay. And I think a follow-up question to that is some people say to me is, well, my mom underwent menopause at, X age, like 55. And so I didn't think it was abnormal. And do you have any kind of thoughts about how you address that with patients or answer that?
Yeah, it is true that the age of maternal menopause is one potential predictor of when you will go through menopause, but it's also not necessarily, completely correlative. And so, there's no magic to it other than to say that if your bleeding pattern is changing, and most people's bleeding pattern does change during perimenopause, and so this is a question we field a lot, but it may not be abnormal that you're still bleeding at 55, but it could be, and so it's a good thing to have a discussion at the very least with your gynecologist.
Great. And again, bleeding around menopause is a very common, symptom that people seek care for. And so, and I think Dr. Urban had fielded, again, I don't know, are the answers going to the whole group? I don't know if someone's shaking their head. Good. Okay. So again, there's resources like the North American Menopause Society and all that. Again, not all bleeding after menopause, of course, is endometrial cancer, but about 10% of the time when women have bleeding after undergoing menopause, it can be due to an endometrial cancer. So that's a pretty big number. So that's kind of our focus today is really, after age 50, if you're still having bleeding, still kind of having period-like symptoms, it's really a time to reach out to a provider, go in, get some advice about next steps to work up. Was there, I think, maybe one more question before we go to the next case, if that sounds right? Someone asked about, the so someone asked about key techniques or suggestions for optimal endometrial sampling. Did that already get answered? Sorry, I'm slow. Oh, Renata is awesome. Okay, Dr. Urban.
Dr. Urban is on it.
Yeah, so, I mean, most of the time it can be done in the office. If it can't be done in the office, then it's what we call a D&C, which is done, or a hysteroscopy, which is done in the OR. And they're very predictive, very, very high sensitivity in predicting cancer. I think over 98%. So, if they have adequate tissue and the pathology is read as having, adequate tissue and not insufficient sample or something like that, then it should tell you your answer. So. Excellent.
The one question, Dr. Gray, if you don't mind, one of our attendees had posted a question about whether hormones or HCG cause cancer. And it's such a great question, but it's such a complex answer. I think, HCG specifically has not been shown to be associated with cancer. So thankfully that is at least a pretty straightforward relationship. Hormones is a much more complex relationship. What I will say is that as it relates to endometrial cancer, having too much estrogen or excess estrogen is definitely associated with a risk for endometrial cancer. And that can be through having excess estrogen, meaning taking hormone replacement therapy that contains too much estrogen, or taking estrogen alone. But there certainly is a very complex relationship between hormones and other types of cancers as well, including certainly breast cancer first and foremost.
Great. Those are great points. Well, I know there's a lot. I mean, it's hard to encapsulate everything with all these cancers. This is just a good stepping off point, but I really appreciate all the questions, and maybe we can come back to some things at the end if we have time. Okay, so next I want to shift to another main cancer, cervix cancer. This line of questioning and case is going to be taken by Dr. Urban, who you just heard speaking. So, kind of the case is around, can cervical cancer be prevented? And the case is KZ, and she's 26 years old, and she's coming to you maybe as a provider, as a friend, wondering when she should be having cervical cancer screening, and then also should she get the HPV vaccine and what that is. So maybe Dr. Urban, if you can kind of talk a little bit about what's cervix cancer and differentiating from uterine cancer, and how do we screen for it?
So thank you everyone again for your attendance today. I think it's the cervix and the uterus essentially, although they really are two organs, they're contiguous with one another. If you all imagine in your head an upside down pear, the bottom part, which is now on top, that wide part is the uterus, and that narrower part on the bottom is the cervix. What's a little bit different about those two organs is that the cervix, the entrance to the cervix, is made up of actually two different cell types. And it's cancers in those areas that are defined as cervical cancer. And what's important to know about cervical cancer is that it's one of the cancers where essentially it's been found almost in 99% of cases to be caused by a virus, by the human papillomavirus. And what's also important to note is that with cervical cancer, there's been found to be a relative lag time between when someone gets exposed to human papillomavirus, when it causes changes in the cervix, when those changes become precancerous, and when it becomes cancerous. So with the screening, actually what we're trying to do is detect precancers before they become cancers. And that's really the importance of then getting screened at the recommended interval to make sure we're picking it up when it's there. What the current guidelines are for starting PAP and/or HPV testing is that every female should start getting screening for cervical cancer as long as they are healthy and their immune system's working normally. They should start at the age of 21. At that time, they should start with getting PAP smears every 3 years. Starting at 30, the screening then goes to either having what's called a co-test, where when you go in to see your doctor, you have your pap smear and testing for the presence of human papillomavirus is done at the same time. If that type of screening is done, the screening is done every 5 years. Alternatively, screening can be done with just a pap smear every 3 years, but it's important to note that for women above 30, what's preferred is what's called co-testing. So having a screening with a pap smear and a human papillomavirus test every 5 years. I think I'm personally really excited as a cancer physician with the idea that there's a vaccine that is cancer preventing. And in essence, that is what the HPV vaccine is. And certainly there are other gynecologic cancers that we're not talking about today, namely vulvar cancer, vaginal cancer, but other cancers, including anal cancer and cancer of the ear, nose, and throat that are related to human papillomavirus that could potentially be reduced with the use of the vaccine.
Yeah.
It's actually recommended by numerous national groups that ideally we want to vaccinate both girls and boys around the ages of 11 to 12. But one aspect related to the vaccination that has recently changed is that the FDA has changed their approval of the vaccine such that people can get it up until the age of 45.
Right.
And this reflects clinical trials done in patients that basically show the vaccine can still be beneficial. And so I think it's a really good discussion to have with your doctor if you're less than 45 and haven't had the vaccine as to whether they think that's a good idea. Lastly, what happens if your pap smear is abnormal? So that is a really complex and great question, especially because what's done really depends on kind of what that abnormality is. Oftentimes, what to do with it can be triaged by adding by an HPV test if it's not been done in a young woman, or the type of HPV that's found. oftentimes what may come after that is another exam with what's called a colposcopy. And colposcopy is basically a technical term for saying visualizing the cervix with kind of a microscopic camera to try to take a closer look at the tissue and then direct biopsies if need be.
So those are, thanks for kind of going through those scenarios. I mean, you know, pap testing, and I know you use the term pap smear, which I still use too, because it's just a different technique they use. There's also like the pap test, and it's really important. You know, pelvic exams don't always include the pap test, right? So people ask that, you know, why am I you know, should I have a pelvic exam or should I have a pap test? And maybe you can kind of talk through a little bit about, you know, I think most people assume when you're getting a pelvic exam, you're getting a pap test at the same time.
And I mean, I think typically, you know, the pap test, and I think, thank you for that correction, Dr. Gray. I definitely I needed that correction a little bit. So, you know, I don't think we can always assume that when you're having a pelvic exam that a pap smear is being performed. Now, thankfully, a pap test in general does not cause discomfort. You may palpate, you know, some pressure in the pelvic area, but I think that's why it can be so hard to know whether a pelvic exam included a pap smear. And so I think that was a great question to ask your doctor before the exam. Are you doing a pap smear? And if so, you know, kind of, and if you're wondering why am I not, I think that's a great question to ask, because sometimes the answer may be you had your pap smear 2 years ago and it was normal, and so we don't need to repeat it. But maybe it was actually, no, you are due today, so we will be doing one, so you know it's going to be done.
Great. Yeah, I think, you know, the pap testing, pap smear, and the HPV story is really one of the success stories we've had in all of cervix, or I'm sorry, in all of, I said cervix, in all of cancer. You know, there's very few cancers where we actually understand what causes it. And, you know, cervix cancer is you know, over 90 or 95% of them are caused by this virus, HPV. And HPV is very common, right? You know, I mean, do most people get exposed to HPV? Kind of maybe you can talk a little bit about that.
That's a great question. So, you know, when there have been really large studies done of populations, the prevalence or the number, kind of the percentage of people within certain groups that have HPV is looked at in age, both in males and females. And in fact, in males and females around in the 20s, the prevalence, meaning the kind of the amount of the population that has HPV, is up to 50%. So it's incredibly common, and that's in kind of those people who get tested. So I think it's important to note that the virus itself is incredibly common, and it's very likely that that someone can get exposed to it, and certainly one of the most common ways is through sexual intercourse, but it can be transferred certainly orally as well, or by kind of touch contact with the genitals. But I think that's also important because it is so common. Not everyone who gets exposed to it then develops cervical precancers or cancers. And screening, as well as why then we look for certain types of human papillomavirus, as well as to determine someone's risk.
Those are, go ahead. Yeah, I mean, I think it's really, you know, HPV is very common, as you said, but most people are able to kind of what we call clear the infection. So that's why, you know, cervix cancer, how common is it? I know
great
the answer,
question. So, you know, again, coming back to your point about it being kind of a success story. So, you know, decades and decades ago in the United States, cervical cancer was incredibly common. And if you look at statistics starting in the 1950s, 60s, 70s, as the pap test was starting to be rolled out, the incidence went down, 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 which is really wonderful. And in fact, really now in the United States, there's only about 13,000 cases per year, which is amazing. What's really challenging about cervical cancer is it remains a huge burden globally. And part of that relates to the fact that countries that have lower resources aren't able oftentimes to implement either the pap test screening or always vaccination. And in fact, even worldwide, there's yearly now still about 500,000 cases of cervical cancer per year and 250,000 deaths. So worldwide, it actually remains a tremendous global health burden. And I think in some ways that's why it's so important that work continues to be done in all countries about how we can best prevent as well as treat the cancer.
And I would add to that, Dr. Urban, absolutely correct. It's a huge burden of disease internationally. And at the same time, there are countries who have really invested in vaccination and in marketing this to their population as a really important intervention. And a country like Australia is anticipated to eradicate cervical cancer as a disease by 2021. And this is it's an immense success, and it really underscores the importance of vaccine.
And I think to the vaccination, we just really, it's really important that, because it falls at kind of an awkward age for vaccination, that vaccination series when they're young, but, around 11, 12, they're not coming in quite as often and all of that. And so it's just really important to make sure that people get their HPV vaccine. And then also, importantly, that they did extend the guidelines. I'm just going to reemphasize this as Dr. Urban, that it used to be that it ended at age 26 of when you should get a vaccination, but now they've extended it to up to age 45. And so really important that even if you've initiated sexual activity before that age, that you should get your HPV vaccine. Very, very important. I did want to, I think someone did bring up, it was in the Q&A about that, when do you no longer need to have pap smears, or should you have them forever?
That's a great question. So I'm actually going to answer two questions that are there. So the first is that if someone has had their vaccination with what's called the Gardasil 4, or the previous Gardasil, do you need to have a new vaccine with Gardasil 9? And what this refers to is the fact that the first Gardasil was against the two most common high-risk HPV types. High risk meaning the risk that HPV causes cancer. There's now a newer one called Gardasil 9 that vaccinates against 9 HPV types. So essentially, if you have had the prior full 3-shot vaccination series with Gardasil or another vaccine called Cervarix, it is not recommended that you get revaccinated with Gardasil 9. It is important to note that regardless of whether you've had the HPV vaccine, you still should be having your cervical cancer screening done. Mm-hmm. The vaccination is incredibly important as a preventative measure, but so is the screening for looking for precancers.
Yeah. Great. That's really, really important. Thank you for addressing that again, because we get asked that a lot. Like, well, if I've had the vaccine, so why should I get pap smears? But really, you should still be coming in for regular pap smears. Vaccines are never 100% preventative, of course.
I think the last question that's also important is, do older women get cervical cancer more frequently? And if so, why are the screening intervals longer apart? So I'm going to answer kind of the first part. So it's not that older women get cervical cancer necessarily more frequently, so much as I think that as a female, as anyone ages, their ability to, as Dr. Gray referred to, clear the vaccine goes down. So in essence, although they're not necessarily, older women are not able to clear the HPV as readily, and their immune system is not always working as well. In addition, there certainly are studies suggesting that there's just sometimes a drop off in screening, and maybe as women are getting older, they're not coming to get screened as often. It is recommended that females get screened for cervical cancer up until the age of 65. And if they've had a prior abnormal pap smear, that screening should actually be continued 20 years from the abnormal screen. So for example, if you've had an abnormal pap smear at the age of 55 and you potentially had treatment or reevaluation for it, you should not actually stop screening at 65. That screening should continue. Now, as to why the screening intervals are further apart, I think what this may be referring to is that between the ages of 30 and 65, the preferred screening is a pap test and HPV. And this has been based on studies of patients that have shown that the predictive effect of having both, meaning how likely it is that cancer is going to happen after a negative pap or a normal, the absence of HPV is reliable enough to persist or predict that for the next 5 years, the likelihood of developing a problematic precancer is incredibly low. And so that's why that's been lengthened out.
I would just give that also caveat that about the ending age guidelines. Just remember though that if you yourself or a friend or someone you know maybe has recently come to the United States and has not participated in an active screening at an earlier age, like for example, if someone has recently immigrated, is age 70 and has never had pap screening, well, they don't fall into that guidelines of don't do a pap. That patient actually is at much higher risk. So just really important to message that out.
The last question, I'm sorry, Dr. Gray.
Go ahead. No, go ahead. No,
the
please.
last question
No,
is,
it's good.
if you've had an abnormal pap in the past with negative follow-up, is the screening schedule still the same every 5 years? It would just depend on your age. So if you were less than 30, it actually would be the pap test every 3 years, but then over 50, or excuse me, over 30, it would be pap test with HPV every 5 years. But that's always, I think, a good question to ask your doctor as well, because how that's managed may be based on the abnormality that you had at the time.
Correct.
Because for some abnormalities, you actually may need to have more frequent checks than every 3 to 5 years.
Yeah. Well, these are great, really great discussion. And again, we can come back to some more questions at the end. We've left time at the end, but I do want to kind of move on to the next cancer topic, which is our third cancer. It's actually the second most common cancer, which is ovarian cancer. And Dr. Jen Burzawa is going to be kind of fielding a lot of the questions along this. So the third case is, you know, kind of how do I know if I have ovarian cancer? And this is a case of ML. She's 62 years old, and she had a really close friend who died of ovarian cancer, and it really affected her because it went so quickly. And she wants to know if she should be screened or can she be screened to detect ovarian cancer. She's very concerned about this. So kind of the questions around like how common is ovarian cancer and who's at risk and do we screen? And so kind of going through those scenarios. Jen. Oops, you're muted. You're still muted. Sorry. I know, I do that all the
time. So I think this is a really great scenario because we see this quite a lot in our practice. I think I had a patient just the other week who had this exact question, was very
common
worried,
question.
Based on having seen a family member go through this. So, I mean, while ovarian cancer is our second most common gynecologic cancer, the good news is it's not that common of a cancer, 1% lifetime risk of developing ovarian cancer for the general population. It tends to affect women once they've been through menopause. So at an older age, usually in their early 60s, the average age of diagnosis is 63. And there are certain women that have increased risk of developing ovarian cancer. So it's always important, if this is a concern, that you talk to your provider about your concerns. Women that are at increased risk of developing ovarian cancer, probably the most important risk factor we know is family history. So having a family history of somebody affected with ovarian cancer, and I want to clarify one thing too. We keep saying ovarian cancer, but there are actually 3 different cancers. So ovarian cancer, fallopian tube cancer, and primary peritoneal cancer that we kind of lump. There's 3 distinct diseases, but we lump together. So when I'm saying ovarian cancer, I'm referring to all 3 of those diseases, and they're all treated very similarly. So a family history is the most important risk. Anyone with a family history that they're concerned about of ovarian cancer, particularly in a first-degree relative, should discuss this with their primary care practitioner, OBGYN, to discuss options for genetic testing that could better inform the risk. Some of the hereditary cancer syndromes carry up to a 40% lifetime risk of developing one of these cancers. And there are, fortunately, interventions that we can offer patients so that they don't develop this.
Oh yeah, I think you kind of addressed some of that, the genetic risk. So, and it used to be, people had bigger families. So sometimes just knowing a family history, it's not as informative. But certainly, as you pointed out, if someone does have like a sister or an aunt or a mother who had ovarian cancer, that would be important to go in and get the testing. So maybe talk a little bit about, are there symptoms though? I mean, are there symptoms that people should be looking for or thinking about?
Yeah, so there actually are some symptoms. Ovarian cancer was traditionally thought to be one of the silent killers that didn't have any symptoms associated with it, but Dr. Goff, actually from our institution, published a large study about some of these potentially more subtle symptoms that have been found to be associated with ovarian cancer. So what I generally tell my patients is anything that's, so the ones that are important are abdominal or pelvic pain, bloating, early satiety and urinary urgency, like needing to feel like you have the urge to urinate more frequently. And what we generally tell our patients is if it's something that's new or different to your body, that's persisted over a few weeks and has happened the majority of days, that's something that's worth talking to your practitioner about. And I think one of the slides highlights the importance of telling them that you're concerned that these symptoms may represent ovarian cancer and letting them decide about how to best approach a workup for that.
Great. Yeah, and I think, again, kind of emphasizing, it's hard because bloating and abdominal pain, those are such common symptoms that people can have, but emphasizing if it's new, it's not like you've had bloating, monthly for many years, but kind of new and over, I think, like 2 weeks of time to, and it's real, I think all of us have seen this, that a lot of times patients have had these symptoms and get kind of attributed to GI causes, and they kind of get sent around to different specialists before they get sent for more definitive testing or even have a pelvic exam. So, so definitely important to kind of be aware of that. I want to switch over and talk a little bit for this particular case, like she asked about screening though. Are there any screens? Like we have these great screens for cervix cancer we talked about, but are there any screening tests we can do for ovarian cancer?
So, to clarify, a screening test is meant to detect a cancer before it happens. So for, as Dr. just said, pap smear is a great screening test for cervical cancer because we can catch it in a precancerous phase. Unfortunately for ovarian cancer, those tests don't yet exist, although it's quite a hot topic of research and has been for a number of years. That being said, for patients that are at a high risk, so have a genetic risk or other risk factors that there are, you can perform an ultrasound and a CA-125, which is a blood test for a tumor marker that, and that's frequently recommended even by the national guidelines. Unfortunately, those tests have never been shown to help us detect ovarian cancer at an earlier stage. So it's not recommended for the general population.
Okay. Yeah. So, I mean, we're working on it. Ovarian cancer has been really a challenge in trying to develop a screening test. And I think we all, are hopeful that maybe one day we could have a more accurate blood test or something that could predict either a precancer or an early stage cancer so that it's caught before it's at a later stage. Again, kind of important, points from this are that, be attentive to your body, for new symptoms. Certainly if you have a family history that you're concerned about, bring it up with your primary care provider. And then if you do fall into one of these higher risk groups, genetic testing, I think there was a question in the Q&A. Renata, someone about the genetic testing?
No,
yeah.
The
Go ahead.
question says, how accurate is genetic testing in determining whether you will get cancer and where it might occur? So I think what's a little, to take a step back in answering that question, I think we have to consider what type of genetic testing you're having. Meaning, are you having genetic testing because there's a family history of cancer and it's an actual test to look for abnormalities in genes? And what that will be able to tell you is, yes, there's an abnormality that is associated with an increased risk, or there's a change in the gene, but we're not quite sure whether there's any significance or everything is normal. And that may be able to help your kind of risk where you are risk-wise. This is a little bit different than, say, studies such as 23andMe, which don't always look for all of those abnormalities. And so I think it's important to note that if you are concerned based on your family history, it's actually best to seek out consultation with a group called medical genetics, where essentially they are doctors that are trained to go through your family history and talk about possible risk and help you get the appropriate testing you need.
I also wanted to clarify one thing, Dr. Gray, about ultrasound. So again, as I mentioned, like a screening test, which is something that should get performed regularly to detect something before it happens, is different than if you're having the symptoms that we talked about of ovarian cancer, in which case you should absolutely discuss them with your provider, and an ultrasound is a great way to start for most patients.
And I forget, there's also some blood tests, right, that we do test for women. I think, did you mention already the CA-125? Yeah. So again, and I think it's just important that, you know, a lot of women, again, all of us see this, they've seen their primary provider, which again, who probably sees ovarian cancer very, very rarely. And so it's much more common for people to have GI symptoms. But I know, you know, women around the age of 60, if they were having some new pelvic symptoms or urinary symptoms, that part of that thought process should be, you know, could this be ovarian or gynecologic, and getting either an ultrasound plus that CA-125 marker, because it is very sensitive for ovarian cancer in someone who has symptoms. So good, really good dialogue. I think there was another Q&A. It was back to kind of some of the bleeding, but maybe let's, so I was trying to think, go ahead.
So the question is, so how can younger women best advocate for themselves when experiencing abnormal bleeding and cancer symptoms? And I think it's a great question, especially because to discuss especially the fact that when those symptoms get presented, I think it's always important to try to kind of, for you to think about, okay, when did this become normal for you and become abnormal for you? Because everyone's normal is kind of a little bit different. So I do think that that's important to consider, as well as kind of what those differences are, meaning, you know, when was your bleeding, what was your bleeding like, and then when it changed, what was it like afterwards? I think what's important to note, thankfully, is that in general, the chance of ovarian cancer and endometrial cancer at younger ages is less. To be clear, not zero, but less. So I do think that's certainly reassuring. The other thing that can be tricky in females before they go through menopause is that oftentimes a CA-125 is not nearly as reliable, because there's a lot of non-cancerous things that can cause the CA-125 to be high. And so that's why just doing it on its own, meaning you feel fine, there's no, you know, there's nothing on ultrasound, is really not that helpful and may actually be harmful. Whereas if you're having those symptoms and bring to the attention to the doctor, discussing whether those are appropriate tests at that time certainly could be different.
And I think a couple other questions came up. One, and I think Elise, you answered it, was that does having a prolapsing uterus or bladder increase your risk of gynecologic cancers? So I'll put that one back to you.
Okay, yeah, fortunately it does not. Although prolapse is exceedingly common and can be a lifestyle issue, it does not have any relationship to cancer, fortunately.
That's good. And then I think that another question, let me just go through, really, really good questions, everyone. I really appreciate this. So maybe back to Dr. Burzawa about a little more specifics about ovarian cancer. And the question was, what's the survival rate if ovarian cancer is caught early?
So the survival rate is actually quite good for early stage ovarian cancer. The unfortunate reality is that we're not very good at catching it early because, as we talked about, we don't have a great screening test. I think one of the important things to highlight is that survival has been linked to care by a gynecologic oncologist. So if there's a suspicion for ovarian cancer, or even the possibility of ovarian cancer, it's appropriate to seek consultation or ask for referral to a gynecologic oncologist for consideration when decision making is being performed and surgery is being performed by an expert.
Great. That's a really excellent point. And again, I think, you know, the age that you're having the abnormality, as you brought up, is important, meaning that, you know, when you haven't undergone menopause, the ovary can make cysts that kind of come and go, and you can have kind of a range of normal within cysts in the ovary. But certainly after you've undergone menopause, where the ovaries are not making cysts or functioning in that manner, if there's abnormalities on an ultrasound or caught up, that really needs to get bumped up to an expert that knows how to manage it. Particularly if there's a suspicion for cancer, then it should be seen by a gynecologic oncologist. I think another question came in again about periods. I know irregular periods are a challenge. So a question came in, are irregular periods concerning? It's a little broad. Maybe back to I guess maybe Elise, because that's kind of the uterine.
Sure. Yeah. No, I'm happy to field this one. So there's a lot of things that can cause irregular periods, right? Many of them are benign and not cancer, and you know, less commonly irregular periods could be due to a precancerous condition or a cancerous condition, and this gets back to just the importance of having a thorough evaluation by a gynecologist, you know, that would include an ultrasound to evaluate for anatomic considerations. There are endocrine or hormonal reasons why people may have irregular periods. And so sometimes they are concerning and sometimes, you know, they're not, but there are certainly ways we can evaluate that, and there are ways that we can actually effectively treat that. You don't have to have irregular periods for your whole life.
No.
There's no good
that.
reason for that, so please seek care for that, please.
Yeah. Yeah. And again, usually most people either start with, you know, starting with just irregular periods, especially, you know, obviously, again, premenopausal irregular periods. Most OBGYNs, this is really their bread and butter and can kind of help manage that. Again, bleeding after menopause really should be a higher concern that needs to get worked up a little bit differently and sent along. And I think we had another question come in. Wait, did someone already answer it? But we can field it live though also. It just went off my screen about, who answered that one?
Renata.
I apologize, I didn't see. Oh, Renata did. Okay, Renata. So this is the question came in. So it's interesting. So what if you have a hysterectomy? So you remove the uterus, but it leaves the cervix. Maybe if someone's had like fibroids, which are a benign condition of the uterus at a younger age, and so the ovaries left in place because the woman might still be premenopausal, and then leaving the cervix because the cervix didn't have any abnormalities. So go ahead, Renata. Mm-hmm.
Oh, great. Yes.
Yeah.
So essentially what I posted is, you know, thankfully removing the uterus does not increase your risk, the kind of risk you had already of cervical cancer or ovarian cancer. So I think that's important to know. But it just is important to remember that those organs are in place. So for example, if you've had what's called a supracervical hysterectomy, meaning removing the uterus, but the cervix is still there, you still need to have cervical cancer screening. Similarly, if your ovaries are still in place, it's also important to remember, should you then have any new abdominal or pelvic symptoms, because there may be a problem that's related to the ovaries, whether it's cancerous or non-cancerous. Dr. Gray, there was two other questions that were in our chat. So the first was, can certain types of birth control mask symptoms of gynecologic cancer? And probably for the most part, I would say no, thankfully. You know, I think that before starting hormonal treatment for abnormal bleeding, it's appropriate you should talk to your doctor about whether there needs to be any kind of assessment for the uterus, and that is oftentimes dependent on your age and on your medical history of cancer.
And in fact, actually, as you know, ovarian cancer risk decreases with over 5 years use of oral contraceptive pills or birth control pills.
There's also a question, if I have a family history of early menopause and ovarian cancer in my aunts, should you be screened earlier? You know, I think that's really a tough question to direct to medical genetics. We also have a really great, so three of our partners actually participate in a multidisciplinary program through the Seattle Cancer Care Alliance called the Breast and Ovarian Cancer Prevention Program.
Mm-hmm.
And that's actually a really great referral service that you can either be referred to through your doctor or you can self-refer to meet with them and talk about, you know, based on your family history, again, do you need to have genetic testing done? If so, what is that testing? And then based on the results, whether there should be any change in screening.
Great. And again, I think, just to follow up to that point, if you are found to have one of these higher risk mutations, most commonly people think of BRCA1 and BRCA2, that we do recommend either screening with ultrasound CA125, or when a woman has finished their childbearing years and is kind of closer to menopause, recommending a complete hysterectomy and removing of the tubes and ovaries as well. So, so I think some more questions is, one is, how common is it for a woman to have more than one gynecologic cancer? I don't know, Jen, you're down on my screen there.
I'm here.
Mm-hmm.
So in general, I would say it's not very common to have more than one cancer in general.
Mm-hmm.
There are some interesting scenarios for our gynecologic cancers. So one are the HPV associated cancers. So, HPV can affect the entire genital tract, and so can put you at risk for cervical cancer, vaginal and vulvar cancer, which we haven't discussed today because they're rarer cancers, but those organs are at risk as well. in addition to, there are other HPV-associated cancers like rectal cancer, anal rectal cancer, as well as certain head, neck, throat cancers. Yeah. So that's one question. In younger women with endometrial cancers are at slightly increased risk of having synchronous primary cancer. So having an ovarian cancer found concurrently at the time of their surgery. So something to be aware of.
And I wanted to bring up that point. We talked a lot about genetics with ovarian cancer. Are there genetic links with uterine cancer then as well?
Yes, there are. So most places incorporate, so for women that have been diagnosed with endometrial cancer, incorporate universal screening. So are doing some sort of testing on the tumor for women diagnosed with endometrial cancer. The risk is in only about 5 to 10% of endometrial cancers we think are hereditary though. So a little bit lower than ovarian cancer.
Yeah.
Yeah.
Go ahead.
And I was just going to add to that. So the
perfect.
universal screening that we're doing in that case is for something called Lynch syndrome, which is a hereditary cancer syndrome associated with other types of cancers like colon cancer in particular. And so it is not very common, as Dr. Burzawa said, but it is high yield when we can identify that and then initiate testing for the patient and also any family members that may be impacted as well.
And those families do tend to have also high rates of younger colon cancer. They're linked with the colon cancer. So just, and you tend to see those cancers kind of clustering in families, both on the, men and the women. So. Okay, good questions. I really appreciate all the interest. I think some of the other things were answered live. One participant asked about sharing this on YouTube. So we'll ask Annie and Tammy to help us figure out how to post that and let people know. Happy to have that be on YouTube. Another question is, why are there so few gynecologic oncologists out there? And Renata, Dr. Urban fielded this. It's a newer specialty relative in our field, but there's actually quite a few in the Seattle area. Our group, we actually have 10 GYN oncologists at University of Washington, and we are happy to take new patients. So, and we take care of women with cancer, but we also take care of women who have a suspicion of cancer or maybe pre-cancer. So we do see a range of patients. Cancer. Or what'd you say?
Or high risk of developing cancer.
High risk. Perfect. Thank you. Yes. So, and we're going to put up a slide. I think we have a slide at the end of how to contact our clinics and all of that, because we really want that to be available for patients.
Dr. Gray, there's one last question that I wanted to answer live, which is a great question, which is, if you've had your tubes cauterized after the birth of your last child, does it have any increase in gynecologic cancer? So this is a mode of what's called tubal ligation, or kind of shutting off the tubes so the eggs can't move from your ovaries to the uterus. And interestingly, tubal ligation, by whatever way it's done, has actually been shown to reduce the chance of ovarian cancer. So thankfully, it does not increase your risk for any type of gynecologic cancer or other cancers. The other part of that question related to fibroids, meaning, are there kinds of concerns you should look for if you have a known history of fibroids? Having fibroids, number one, is incredibly common. Up until probably about a third of women in the United States, or females in the United States, have fibroids, and they may not realize it. And they themselves are non-cancerous tumors of the uterus. I think what's though tough is that when you have them, it can create symptoms of heavy bleeding with periods. And so I think what's important to know, if you know you have fibroids, is again, whether you're having a change in what is a typical pattern for you in either your bleeding or kind of how you're feeling in the pelvic area. Meaning, if you know you have fibroids but haven't had any pelvic pressure or heavy bleeding and are now starting to have some, that is definitely something you should call to attention for your doctor or care provider.
Okay, I'm just going to look again at our Q&A. Really, I thought this was really an excellent webinar. I was really happy to participate and really want to thank my co-panelists and really thank all the attendees for coming and your interest. Gynecologic cancers, we always feel like don't maybe quite get as much publicity, if you will, than some of the other big cancers. One kind of alarming thing that we want to get the message out is, you know, during this COVID pandemic, one of the really other side stories that's been awful has been that we've seen a decrease across the board in all cancers of new diagnoses of cancer of about 30 to 50%. Sadly, that doesn't mean that we cured 30 to 50% of cancers miraculously. It's that patients aren't coming in, right? We're in the middle of a global pandemic. People are afraid to come in to see their providers. There's people are losing their jobs. There's a lot of stress out there. And so really want to emphasize we want patients to come in. It's incredibly safe. We're not wearing our masks now, but we all have them nearby in the hospital. It's very safe to come in and get care. We've adopted ways to keep people safe from COVID very early on back in March, and really want to emphasize, if you're having symptoms, if you're having any concerns, gynecologic, you're worried, you know, if you're having abnormal bleeding, need follow-up on an abnormal pap smear, please, please, please do come in, make appointment, because all of us are seeing, you know, cancers that have been delayed, and we can't have that. We have to, you know, really encourage patients to come in. So we put this slide up. Again, I want to thank Dr. Simons, Dr. Urban, Dr. Burzawa, thank Annie and Tammy for allowing us to host, and really to thank all of you guys for participating. Please feel free to share the video with anyone. Up here on the slide, Annie, I guess you can do your closeout.
Sure.
But anyway, really fun participating for me.
Thank you all so very much. That was a great panel and really good, very helpful, timely information. This is a slide with information for making an appointment. We have direct numbers to our clinics at both Montlake and Northwest, and at Valley Medical Center on the south end. You can also make an appointment on the website, uwmedicine.org. Yes, we will be posting this great panel discussion to the UW Medicine YouTube channel, so look for that in a few days, and we'll also make sure to email the link to everyone who has registered. For more information, you can also reference the Foundation for Women's Cancer. They have a great website. They're a nonprofit dedicated to increasing public awareness of gynecologic cancer risk awareness, prevention, early detection, optimal treatment. And also the Society of Gynecologic Oncology. It's the world's premier organization for everyone who works to cure gynecologic cancers. It's a hub for patient care, education, and advocacy, and they have a really strong patient resources section on their website. Also, the Seattle Cancer Care Alliance has more than 300 clinical trials open for patients. This morning I looked, and there are 18 current trials for gynecologic cancers listed. And then just to add to this, our partner, Right as Rain, they have an amazing digital zine online at rightasrain.uwmedicine.org. It provides health and wellness tips, news, and information brought to you by the experts at UW Medicine in Seattle. So I hope that you'll check that out. Thank you so much for joining us today, and to all of the panelists for sharing your expertise. Have a safe
Thank you all.
2020.
Thank you.
Thank you.
All right, stay safe, everybody. Okay, take care.